Why don't we go ahead and get started? First of all, let me welcome everyone to Psychiatry and Behavioral Sciences Grand Rounds. It's my pleasure to introduce our speaker today, Dr. Scott Beach from Massachusetts General Hospital. So just a brief bio about Scott. He's the program director for the MGH McLean Adult Psychiatry Residency program. He's an attending psychiatrist on the MGH Psychiatry Consultation and Acute Psychiatric Services, and is an Associate Professor of Psychiatry at Harvard Medical School. He attended the University of Virginia School of Medicine and completed a residency in adult psychiatry at the University of Virginia. He then finished a fellowship in CL Psychiatry at MGH, and has been kicking ass and taking names ever since. So he's developed expertise and has written some of the field's seminal articles in areas like QT prolongation and psychiatric medications, catatonia and related syndromes. He's now developed, setting the pace in neuropsychiatric effects of COVID-19, which is why he's here today to speak to us. He's authored over 50 publications and 25 book chapters, which is just amazing, Scott. And he is a leader in the Professional Society for CL Psychiatrists, the Academy of CL Psychiatry, and helps to organize and run the annual symposium. So I just want to welcome Scott to University of New Mexico, and we're really looking forward to your talk on delirium and neuropsychiatric effects of COVID-19. So I apologize, I did not find or prepare any embarrassing slides about you, which would have been in keeping with tradition. So I feel I let you down, but I'll just go ahead and let you take it away.
Thanks, Davin. I greatly appreciate that. And I'll just say that it's wonderful to be here. I've had the fortune of knowing Davin for a number of years. And as we were talking about before, getting to train some UNM med students over the years. So Brittany Albright and Flan Meredith, and most recently, Dr. Kilgore, who's now back with you all. So it's great to be here. I'm going to talk today about delirium and other neuropsychiatric manifestations of COVID-19. There's a huge amount to talk about with regards to COVID, and I'm really going to focus on acute and to a lesser extent subacute manifestations of COVID. So I'm not going to talk so much about long COVID, which is where I think a lot of the exciting work is to be done. So we're going to focus on more of the acute side. And I also want to say that there is so much literature that has come out over the past 2 years about neuropsychiatric complications of COVID that I absolutely do not consider myself to be an expert. And one of the most fun things about giving talks like this is that I end up learning so much from people in the audience in terms of things that they've read and things that they're doing in terms of this. So I'm hoping we can save some time for discussion and questions at the end. I don't have anything to disclose with regards to this talk. So I'll start by saying that we knew pretty early on that COVID was doing something to the CNS. And one of the earliest signals that it was getting close to the CNS was the high rates of patients who were developing anosmia and ageusia. And in one study, it suggested that up to 90% of patients in the initial COVID wave developed one of those symptoms. Interestingly, there's now some evidence that Omicron is less likely to cause those symptoms, and we can talk a little bit about that. It's probably more like 25% ageusia and 12% anosmia with Omicron, but certainly high rates early on. There were also a variety of other neurologic symptoms that were being described. So patients were coming in with strokes, particularly young, healthy individuals. And in one study, the odds ratio for stroke in the setting of COVID-19 is actually about 3.5 times the base risk. And so that's a pretty significant increase. And then a variety of neurological syndromes, many of which are quite rare otherwise. So Guillain-Barré syndrome was described, transverse myelitis was described, something called acute hemorrhagic necrotizing encephalitis, which is almost never seen in adults, was described. There's now been some cases of viral encephalitis and ADEM, as well as PRESS. So lots of neurologic phenomenon. And then as we started to think about long COVID, we got these descriptions of dysautonomia, which is also described in the acute setting, but seems to be a particular problem in patients who have long-term consequences of COVID. And then what we'll focus a little more on today is the phenomenon of encephalopathy and delirium. And overall, a recent study suggests that among hospitalized patients, almost 14% developed some sort of new neurologic phenomenon, and that does not include anosmia or agousia, so it's pretty significant. One of the things that I want everybody to keep in mind as we go through this talk, though, is this question of association versus causality, and I think that's one of the biggest unanswered questions when it comes to COVID. So we have all these neurologic and neuropsychiatric phenomena that have been described in the setting of COVID. And I think for some of them, we're starting to be able to say that they are caused by COVID. But for a lot of them, it's really still an association. And we don't really know if the virus is causing them, if some sequelae of the virus or the body's reaction to the virus is causing them, or if it just happens to be a sort of incidental association or incidental finding, if you will. And I think that's a really important question as we go forward. If we think about workup for some of the neuropsychiatric consequences of COVID, there have now been a few good studies with at least 100 or more patients that have sort of characterized findings in various tests. With regards to EEG, it turns out that the findings are pretty non-specific. So for patients with neuropsychiatric symptoms who have had an EEG, mostly they have an EEG that's consistent with delirium. So generalized diffuse background slowing, sometimes frontal slowing. There's very few that have demonstrated evidence of seizure activity, and seizure is not on the list of things that is thought to be caused by or increased by COVID, unless there's another underlying brain pathology sort of driving that. There have been a couple good studies now looking at CSF studies in COVID, and the most common findings are illegal clonal bands, which we probably associate most with multiple sclerosis when we're taking the boards, but are really just a sign of inflammation. And then some findings of elevated protein, which can be associated with encephalitis. In terms of the actual virus, that has also been found in the CSF, but only in about 6% of tested patients. And keep in mind that these are patients for whom the suspicion is very high that there's a significant neuropsychiatric consequence of COVID. So it's not to say that 6% of all patients with COVID have virus in their CSF, but in that subset, in some studies, up to 6% of patients have been found to have the virus in the CSF. If we think about imaging, there are a few distinctive neuroradiologic patterns that have emerged. Probably the most common one is a pattern that is described as being similar to what we see in some autoimmune encephalitis. So in an anti-NMDA receptor antibody encephalitis, we sometimes get these signal abnormalities in the medial temporal lobe, and that's a pattern that has been described in the setting of COVID as well. And then several patterns consistent with vascular disease, white matter, microhemorrhages, and lesions of that nature as well. If we think about delirium specifically in COVID, it's estimated that something like 75% of COVID positive patients in the ICU develop delirium. And that, when I first saw that number, I thought, well, that's pretty much the same as all comers in the ICU, but it turns out that the ICU number these days is actually more like 25 to 30%. And so that's actually a significantly higher percentage than we might expect in the ICU in general. The risk factors are similar. Older patients are more likely to be delirious, sicker patients are more likely to be delirious, and patients who are on more medications are more likely to be delirious. There's an interesting study that suggests that family visitation is associated with a lower risk of COVID, but obviously in most of our ICUs, family visitation hasn't really been an option for most of the pandemic, and especially for COVID positive patients. Interestingly, the median duration of delirium in a lot of studies is on the order of 3 to 5 days, which I would say actually seems a little bit short compared to our experience. And it seems like a majority of patients have a hypoactive delirium, which again is somewhat consistent with delirium in general. One of the questions that we asked ourselves early in the pandemic is, are we surprised by these high rates of delirium? And in many ways, maybe we shouldn't be. So we know several things to be true with regards to delirium in general. One is that patients with dementia who are at an increased risk for delirium are also, it turns out, at an increased risk for COVID, and the strongest effect is vascular dementia. So early in the pandemic, a lot of older patients who were being admitted were patients who were in long-term facilities who had dementia at baseline and were going to be at higher risk for getting delirious anyway. We also know that COVID positive patients tend to be sicker. They have higher rates of ICU admissions. They have higher rates of ARDS, and we know that sicker patients in general get delirious. And they also require more sedation because of respiratory complications. So especially in the first wave, we were seeing patients on 3 sedating agents, which is not that common in our ICU. And so patients were requiring a lot more sedation, and that's obviously going to drive up rates of delirium. And another phenomenon that we were seeing was a shift towards using older sedatives. So whereas most times in the ICU when we're consulted on patients, we're seeing patients who are on dexmedetomidine or propofol, early in the pandemic, we saw a lot of patients on midazolam and fentanyl because there were concerns about supplies of some of the newer agents. I want to take a step back and talk a little bit about our experience in Boston in the early phase of the pandemic, because I think it sets up some of the things that we observed in terms of delirious patients in the hospital. So Boston was hit early by the pandemic. We were a couple of weeks after New York, and we had a super spreader event very early on, which was the Biogen conference that actually took place just across the river from Mass General. So the first COVID patients in Boston arrived at Mass General on March 1st, and this gives you just a timeline of things that followed. So March and April into May of 2020 was kind of our first wave peak. This is a now outdated graph, but shows you through February of 2021 what our COVID numbers looked like, and you can see that pretty dramatic peak for our first wave. As our cases rose, our staff were deployed throughout the hospital, and there were a bunch of additional units that were converted to COVID units, as well as numerous additional ICUs that were stood up throughout the hospital. Most PGY2 and PGY3 internal medicine residents, as well as most hospitalists, began staffing ICUs exclusively, whereas the COVID floors were staffed primarily by subspecialist IM attendings, mostly outpatient attendings, and residents from other departments, including psychiatry, who were deployed to staff these non-ICU COVID floors. And I talk about the staffing because it leads into what we experienced on the consult service, was that initially our volume dropped pretty precipitously, but then we started to get called a lot on COVID patients, and we tended to have consults that fell into one of 2 groups. Most patients we were seeing were sicker and more behaviorally complex than the average psychiatry consult. So these were patients in the ICUs with COVID who were extremely medically ill and very behaviorally complex, often with very significant agitation. And then a smaller subset were more straightforward questions that were usually handled by the primary team, but now that there were physicians covering those non-ICU COVID floors who weren't used to doing internal medicine inpatient work, we got a few more consults to help those out as well. Within 3 to 4 weeks, though, our volume was sort of back to normal. So beginning in mid-March, we started seeing COVID patients with prominent delirium, and the first 5 or 6 cases were really striking in their similarities. Many of them were older men with underlying cognitive vulnerabilities. And for several of them, the mental status change was actually the only indication of infection with COVID. So there was no other systemic symptom. They didn't have a cough, they didn't have a sore throat, they didn't have a fever. They presented to the ED with altered mental status. They got a COVID test because of their altered mental status, and they were found to be COVID positive. All of them had significantly elevated inflammatory markers, and their delirium was one of extremes. They were either incredibly hyperactive with very hard to control agitation, or they were extremely hypoactive and immobile. We also noticed that they had some unique features of delirium. All of them had multifocal myoclonus. Now, that's not a unique feature of delirium. It's actually been described as one of the most common neurologic findings in delirium, but it was striking in terms of the sort of universality of it and how prominent it was. So it was really obvious multifocal myoclonus in these patients. Several of them also were noted to have increased tone. A couple of them had good reasons for this. They may have been on antipsychotics at baseline, or they had some Parkinsonian features at baseline, but several of them really didn't have another reason to have increased tone. And then there was this triad of symptoms. They were withdrawn, meaning they weren't spontaneously eating or drinking or engaging. They looked abulic, and they were alogic. So they had significantly decreased speech output. And in several cases, this was rapidly evolving. So they went from sort of normal to very impaired in the course of 1 to 2 days. And I'll just point out that another thing we were contending with was trying to do some consults virtually. And Dr. Kilgore was living this experience. So she was on her CL rotation during this first wave and during the peak of all this, and seeing some of these patients with sort of odd delirious features. So that got us thinking about what might actually be happening in the brains of these patients. And we had a couple of ideas, some of which have turned out to possibly be theoretical in terms of what's happening with COVID. So we think about primary mechanisms and secondary mechanisms. We thought that it was possible that some of these patients might have a COVID encephalitis, that they actually had virus in the brain that was driving some of these symptoms. And as I mentioned earlier, we've now had confirmed cases of SARS-CoV-2 in the CNS, though that seems to be the exception rather than the rule. We also wondered about this idea that patients had a lot of anosmia, so that would suggest that the virus was getting into the nose, and we thought about the possibility of it getting into the olfactory bulb and kind of tracking into the brain from there. That remains a prominent theory as to how COVID might get into the brain. And in fact, with the original SARS, mouse models have demonstrated that that can in fact lead to invasion of the brain, and specifically the thalamus and the brainstem. And I mentioned this happy hypoxia phenomenon. We didn't observe this, but many people in New York in the very first days of the pandemic observed this phenomenon of people presenting to the ER walking and talking with oxygen saturations in the 60s. And that was a phenomenon that was never really well explained. And so one of the ideas was, might there be virus in the brainstem that's actually leading to a central hypoxia that's sort of driving that? But then there's also a whole host of secondary mechanisms by which delirium might occur. So obviously many patients had ARDS. They might be hypoxic, leading to oxidative stress, or they might have multi-organ failure, leading to hyperperfusion. And we know that CVAs are increased, so some patients probably had small strokes that might be leading to cognitive changes. There's also this idea of a massive systemic inflammatory response leading to cytokines crossing the blood-brain barrier and kind of driving delirium in that way. And there's a perhaps similar phenomenon when patients undergo CAR T therapy for certain forms of cancer, where they have a cytokine release syndrome that occurs with that. And interestingly, a lot of the neuropsychiatric sequelae of CAR T therapy look sort of similar to some of the things that have been described in COVID. Another idea is that perhaps some patients might develop a delayed post-hypoxic leukoencephalopathy from the hypoxia that occurs in the setting of COVID, and that might drive some of the cognitive symptoms. And as I'll mention a little bit later, there's actually a small amount of evidence for that in some patients. We also thought about a hybrid model. So maybe it's not one or the other, but maybe COVID can cause both a primary and a secondary encephalopathy. And this would make it similar to HIV, where you can have macrophages enter the brain, leading to a series of events with inflammatory cytokines crossing the blood-brain barrier, but also get direct viral invasion. And in fact, Greg Friccione on our service observed that many of the things that we were seeing in patients were very similar to what he saw in patients in the early days of the AIDS epidemic, when patients had a lot of depression, speech latency, and alogia as a result of direct invasion by HIV. Another hybrid model would be endotheliitis. So the idea that SARS-CoV-2 sort of breaks down the endothelium, and that leads to a breakdown in the blood-brain barrier so that both cytokines and the virus itself can get into the brain in that way. Many of these questions are still unanswered. We don't have a great sense about how exactly the virus gets into the brain, but I would say there is increasing evidence for at least some degree of primary invasion, and I'll mention that in a few slides. This is, depending on whether you're a visual learner, this is either a wonderfully helpful or a completely overwhelming diagram. It was put together by Nate Prashan, who was one of our residents who was doing some work with us at the time. But it essentially sort of consolidates all of those possible mechanisms and suggests ways in which COVID-19 may be driving delirium in various patients. When we think about the workup of a patient who might have a COVID-19 delirium, I would highlight a few things. And I think the biggest take-home message is that any patient you see with altered mental status currently should be tested for COVID. So the WHO now considers altered mental status to be a core symptom of COVID. And in a study that came out of our emergency room, delirium was the 6th most common presenting sign in patients with COVID. And over a third of patients who presented with COVID, with delirium in the setting of COVID, did not have associated symptoms. So just the presence of altered mental status should trigger a COVID test as part of the workup. In terms of other studies, EEG and CSF findings seem to be less helpful. They're unlikely to be specific, and so we generally are not recommending those studies, especially given that the utility of any test in the setting of COVID has to be balanced against the risk of further exposure. So even when we think about EEG as a pretty benign test that we often recommend, in the setting of COVID, it requires an EEG tech to be in the room with the patient for 15 to 20 minutes at least, and that's a significant exposure. And so we want to think about the balance of that as well. If any additional study, I might recommend an MRI. That seems to be the most likely to reveal some specific pathology, though we don't have a great sense of how to change management in the setting of an abnormal MRI for somebody who has a COVID delirium. When we think about management, we want to first think about it similar to the way that we would manage any patient with delirium. And so we want to think about behavioral and environmental approaches first. That includes things like choosing your sedation wisely. So one of the things we worked with internal medicine and ICU teams around early on was the idea that if you had patients who were going to be at higher risk for delirium based on other factors, that you might want to preferentially use a sedation agent like propofol or dexmedetomidine in those patients, and use things like Versed and fentanyl in patients who might be at lower risk for delirium. Also, always thinking about minimizing other CNS active medications, and then things like orienting patients and occasionally using net beds as something that can reduce the time in physical restraints. If you have an incredibly agitated patient who is constantly in physical restraints because of their COVID delirium, we had a couple of cases where net beds were helpful just to reduce burden on nursing staff. As with all delirium, medications manage sequelae rather than treating the delirium. So hopefully this is a principle that we're all now aware of. We don't have medications to treat delirium, and the treatment should always focus on the underlying cause, but we do have medications that can be helpful in managing sequelae of delirium. And in the setting of COVID positive patients, we thought about using medications specifically for agitation, for prominent perceptual disturbances, or for signs of catatonia or akinetic mutism. And as we thought about which medications to use, we had a few unique thoughts with regards to COVID, one of which was this earlier observation that many COVID positive patients with delirium seem to have some increased tone. So we had a little bit more concern for EPS in the setting of antipsychotic use. And then early on, we were using a lot of hydroxychloroquine and a lot of azithromycin. And so we had a little more concern for QT prolongation with some agents. We also found a strong preference for parenteral agents, given the severity of agitation and medical comorbidities. This led to us trying to come up with an algorithm for how we might approach management of delirium in the setting of a patient with COVID. So we kind of put our heads together and thought about this from an expert consensus standpoint. Unbeknownst to us, at the same time that we were doing that, a group at Stanford was also doing it. And while there is not a strong evidence base for this algorithm, I can at least say that the two groups independently came up with pretty much the exact same algorithm. So there is at least some expert consensus on what we might do for these patients. The first agent that we thought about using is melatonin. We tend to use that a lot in the hospital for general delirium because of its sleep regulating effects. But one of the things that's interesting about melatonin in the setting of COVID is that it actually has some immunomodulating effects. And so for patients for whom their illness, their physical illness, may be primarily driven by an overactive immune response, melatonin might actually help to dampen that a little bit. And so we generally recommended melatonin for COVID positive patients with delirium. The one exception would be if you have somebody for whom there is evidence of an inadequate immune response, so maybe somebody who's immunosuppressed at baseline, then you want to be careful using melatonin in that patient because the melatonin might further suppress the immune response. The big difference in our algorithm in terms of what we would normally do for delirium and what we would do for COVID is that we put a slightly higher priority on using alpha-2 agonists in the setting of COVID. And this really came out of some observations that patients who were on dexmedetomidine as their sedating agent seemed to be doing much better in terms of their risk for delirium. So because of that, we reached for clonidine a little more quickly than we would typically. And whereas we might reach for an antipsychotic in a non-COVID positive patient, we delayed that a step because of some of the concerns about EPS and QTC. And again, because we saw that alpha-2 agonists seem to be working well. So we ended up using a fair amount of clonidine in patients with COVID. It was particularly helpful to wean people off of dexmedetomidine and then put them on a clonidine patch. And then we use some oral clonidine as well for agitation. The next step in our algorithm was then to think about antipsychotics, especially for ongoing agitation. We decided that we would prefer to use low potency agents given this potential risk for EPS and given some of the risks for catatonia that I'll describe. And so early on, we used a lot of chlorpromazine because it's easy to give, it has an IV form, it's low potency, it has a wide dose range. As we got more comfortable, we did eventually feel comfortable using intravenous haloperidol for patients with COVID, despite the fact that it's a high potency agent. And one of the things that's interesting is that there's some evidence that haldol may be helpful for COVID, even independent of delirium, because it's one of the medications that acts on sigma receptors. And sigma receptors have now been looked at quite a bit in COVID. We also have observed over the years that intravenous haloperidol, for reasons we don't fully understand, seems to cause less EPS than oral or IM haloperidol. And so from the EPS standpoint, we were a little more comfortable giving IV haloperidol. Overall, I would say the medications that we most commonly used in the setting of COVID delirium were Thorazine or chlorpromazine, olanzapine, and haloperidol were probably our top three. Olanzapine has the advantage of being available in dissolvable and IM forms. Some people are even starting to use IV olanzapine, particularly in emergency room settings, but also on the floors. And there was an interesting discussion on the ACLP listserv early on about using aripiprazole specifically for patients with a hypoactive delirium, but who had prominent perceptual disturbances. Aripiprazole typically isn't great for managing agitation in delirium, but might be helpful for a hypoactive delirium. If patients were still having sort of breakthrough agitation on an alpha-2 agonist and an antipsychotic, then we might think about using something like valproic acid or trazodone. We use a lot of valproate on our consult service for patients who have an underlying dementia and have some impulsivity or dysexecutive function. And so we started using some valproate in COVID-positive delirium as well. And then trazodone's a useful agent if patients are able to take PO kind of for daytime impulsivity and restlessness as well. Finally, in terms of other things that we thought about, but we didn't end up using a lot of, so dopamine agonists. I'm going to talk a little bit about the phenomenon of akinetic mutism or catatonia in COVID. There were a couple of patients who looked akinetically mute, and we decided to try some amantadine, in one case to try some methylphenidate, and we didn't have a ton of success with that. So not to sort of rule it out completely, but in our very small number of patients whom we tried on dopamine agonists, didn't seem to be particularly helpful, and important to balance that, especially in somebody who's delirious, because of the potential for worsening the psychosis in the delirium. And then benzodiazepines, often avoided in delirium in general. We were particularly cautious about them in COVID patients, given the potential for respiratory suppression. But for patients who looked like they might have features consistent with catatonia, I think there's a reasonable argument to be made to at least try a benzodiazepine in that situation to see if the catatonic symptoms will improve at all. So let's talk about this phenomenon of catatonia and akinetic mutism in COVID-19. There were some early reports. The first one I think was in Psychosomatics, and then a discussion on the ACLP listserv, where people were seeing what looked to be catatonia in the setting of COVID. And I mentioned that we observed at MGH this group of patients developing a triad of withdrawal, abulia, and alogia. And certainly when we see those symptoms together, most of us think of catatonia. We initially tried to give these patients benzodiazepines, and we didn't see much of a response. And so we started to think about other things that might look like catatonia. And one of those is this phenomenon of akinetic mutism. People over the years have speculated that akinetic mutism may be on the same spectrum as catatonia. Maybe it represents a pure motor catatonia. It does tend to lack some of the features of catatonia, so it often doesn't have some of the behavioral components like waxy flexibility and echophenomenon. It also seems to lack the affective component of catatonia, which is usually an intense fear response. But interestingly, one of the ideas behind akinetic mutism is that it's a vulnerability that is increased by states of dopamine depletion. And it turns out that a massive state of inflammation in the body, as occurs in many patients with COVID-19, can actually lead to a state of relative dopamine depletion. So one of our hypotheses was that perhaps what we were seeing was actually akinetic mutism that was being driven by a hyperactive immune response. Interestingly, there was later some evidence, I mentioned earlier, that some patients with COVID-19 may actually have a clinical picture consistent with delayed post-hypoxic leukoencephalopathy, and akinetic mutism is a subtype of DPHL. And so we also wondered if some of what we were seeing was DPHL, and that was driving the akinetic mutism in patients. We've since done a little bit of a review on akinetic mutism in COVID, and there's actually been a fair amount written on this, with one study suggesting akinetic mutism in up to 13% of COVID positive patients, mostly after extubation. There seem to be 3 subgroups of patients that are susceptible to akinetic mutism: those with severe respiratory illness, those with a meningoencephalitis, and those with pre-existing neuropsychiatric vulnerability. And again, there's a lot of speculation about what might be driving this, but there is at least one study using magnetic resonance spectroscopy that has shown a pattern in some patients similar to DPHL. We didn't have a lot of success in treating akinetic mutism. So I mentioned that we tried things like amantadine, which has some evidence behind it. We even in a couple of cases tried a stimulant, and we didn't find anything that seemed to work well. But what we actually observed was that time seemed to help the most. We had 2 patients on our service in the first wave who were so akinetically mute that they were actually transferred to the palliative care service and sort of put on comfort measures. And within 2 to 3 weeks, they actually improved, one of them to the extent that he walked out of the hospital. And that was pretty striking. So it seemed like it was just a matter of giving the brain time to sort of recover from this state. Some of us have also wondered, given the huge amounts of apathy that are described in long COVID, if part of that may be on the same spectrum as akinetic mutism as well. So I'm going to switch gears a little bit, going from talking about things that we were seeing on the medical and surgical floors, like delirium and akinetic mutism. And for the remainder, I want to focus a little bit on some other psychiatric phenomenon that have been described in the setting of COVID. And specifically, I'll talk about psychosis. I'll talk a little bit about mood disorders, and then talk about some longer-term cognitive disturbances as well. So with regards to psychotic disorders, one thing to know is that patients with schizophrenia are at significantly increased risk for contracting COVID, and they're at significantly increased risk for dying from COVID. And also, it's important to know that clozapine levels are significantly affected by any acute infection, but seem to be particularly affected by COVID, in some cases doubling in the setting of an acute COVID infection. So some of our physicians who work in the clozapine clinic have actually taken to the practice of reflexively reducing the clozapine dose, sometimes even cutting it in half in any patient who tests positive for COVID or develops significant symptoms that might be consistent with COVID. New episodes of psychosis have also now been pretty frequently reported in COVID. There are over 100 cases of new onset of psychosis in the setting of COVID-19. And in one study out of the UK of patients with altered mental status, nearly a quarter of them had a non-delirious psychosis. The symptoms of psychosis have included delusions, hallucinations, disorganized thinking and behavior, and catatonia, so for sort of the full spectrum. And interestingly, the most common presentation looks like a brief or reactive psychosis, something that would be similar to what we call acute or transient psychotic disorder. And the mean age is much higher than would be expected for a new onset psychosis, so something like 40 to 43 in a few of the studies that have been done. This raises a really interesting question about causality. Can COVID-19 cause a new onset psychosis? Well, we know that there's increasing evidence in general for infection as a cause of psychosis. There are some GWAS studies that suggest that. There are some epidemiologic studies that suggest that. But there are also a lot of confounding factors. Delirium is at play, medication effects in a lot of these patients. They're on steroids, they're on other things that are associated with psychosis. Some of them, it turned out to have a prior history of psychosis. Some of them have substance use. Some of them are postpartum and have other reasons or other conditions that are associated with psychosis. So it's really hard to kind of separate this out. There's also, because this is all case report literature, a really strong selection bias. There's one study that suggested that the risk of a new onset psychosis in the first 90 days after COVID is actually no different than the risk of a new onset psychosis in the first 90 days after influenza or after an upper respiratory infection. Though interestingly, when relapses were included, the rate was higher than for those control events. So I think the jury's still out in terms of whether COVID-19 really causes a psychosis in a broad way. But interestingly, there are some really amazing case reports that suggest mechanisms for which COVID-19 might cause psychosis. And one of them has actually isolated a novel antineural autoantibody that is unique to COVID. So there's at least one described case of a patient with a new onset psychosis, sort of a manic appearing psychosis, who was actually found to have this novel autoantibody in the setting of COVID infection. So I think that raises a lot of questions about whether autoimmune processes in the brain may be driving part of what we're seeing in terms of psychosis in COVID. Another area that I think is going to be talked about a lot over the next few years is this connection between COVID and longer term cognitive disturbances, and particularly dementia. So the first signal for this came in an article last year that reported that the incidence of a first diagnosis of dementia in the 90 days after infection was 1.6%, which was 2 to 3 times the risk for dementia compared with other health events, but interestingly, not higher among patients who were hospitalized. So that was the first signal that there might be something that's leading to longer term cognitive disorders. There's been a few more studies since then. One study out of Cornell looking at hospitalized patients found deficits in working memory, set shifting, divided attention, and processing speed after discharge. And interestingly, in that study, again, executive dysfunction was not associated with length of intubation or premorbid disease. There's also a study in preprint that's out of the UK Biobank that actually suggests some brain shrinkage in the setting of COVID with loss of gray matter in several regions in the brain. There's a couple of studies at autopsy that have looked at this. Early on, there was a report of SARS-CoV-2 found in a brain in the frontal lobes. That report was controversial. Many people felt that the virus probably was not in the brain tissue itself, but was in the vasculature and had kind of leaked out. But there is some emerging evidence to suggest that COVID may cause changes in the brain. There are microglia changes similar to those seen at Alzheimer's in an autopsy study. And another preprint out of the NIH suggests that SARS-CoV-2 RNA was found in a high proportion of brains at autopsy. There's also this interesting study that just came out suggesting that hospitalized patients with cognitive symptoms but no prior history of dementia have elevated levels of proteins that are associated with dementia, including phosphorylated tau. And so there's now speculation about whether COVID might stimulate some processes that are similar to what we see in Alzheimer's and other forms of dementia. Overall, I would say the jury is still very much out in this regard. I think there's a lot of potential confounders, a lot of patients who are hospitalized for any reason develop delirium and then develop longer-term cognitive sequelae as a result of that. Some estimate that 5 to 10% of delirious patients never really recover from their delirium. And at the same time, I think we're seeing some emerging evidence of actual changes in the brain that at least raise the question of whether COVID can cause a longer-term major neurocognitive disorder. Finally, with regards to mood disorders and suicidality in COVID, depression has been described as a common outcome. The timeline is usually somewhere between acute and subacute, so on the order of weeks rather than to days. Interestingly, mania has not been that commonly reported, though several of the cases of psychosis do include maniform features, but that's not been a common description in the setting of COVID. And there have been a couple of studies looking at rates of suicidality, finding that they didn't necessarily increase early in the pandemic, but that they may have increased in certain populations that may have been related more to structural factors. A final note on antidepressants. I think many people have heard this now, but I mentioned earlier about the idea of sigma receptors potentially helping with COVID. And I think one of the most shocking pieces of news out of the pandemic is that of all of our medicines, fluvoxamine might be the thing that helps COVID patients. So this was a study out of UVA that found that fluvoxamine actually led to a lower likelihood of clinical deterioration. And the idea there is that it may be related to sigma activity of fluvoxamine. Interestingly, there's been some other studies to suggest that it's maybe not just fluvoxamine, but it might be true of other SSRI antidepressants and even some non-SSRI antidepressants. At this point, I don't think there's any good evidence to suggest that any patient who gets COVID should be put on an antidepressant, especially given the numerous drug-drug interactions with something like fluvoxamine. But it is interesting, and I would say certainly an argument for making sure that patients who are on antidepressants at baseline who get admitted for COVID are continued on their antidepressants during the hospitalization. Post-COVID outcomes studies have also raised concerns about anxiety and PTSD as potential sequelae, as in addition to the mood disorders. And overall, the risk of a first psychiatric diagnosis following COVID is thought to be maybe as much as twice that the risk after flu. So it does seem like there may be something unique about COVID, but again, I think there's so much related to that. Is it the infection itself? Is it all of the sort of stigma associated with having COVID? Is it the anxiety about catching COVID? Is it the worry about the worry, so to speak? I think there's a lot more questions to be answered in terms of what the actual risk is with regards to COVID. And then finally, just a note on long COVID. I think this is going to be the most exciting area of study over the next few years to try and figure out what it is, what's driving it, and what we can do to help these patients. There are some imaging studies, some FDG PET studies that suggest that there are real changes in the brain in long COVID. There are objective evidence of cognitive dysfunction that's emerging, but thus far we haven't found medications to be hugely impactful in terms of helping patients. So I think we have a lot of work to do in terms of figuring out how we can get patients better who are suffering from long COVID. I'll end there with a bunch of thank yous. I want to acknowledge that I had the luxury of focusing on running a residency program during the first wave, and that meant I was not on the front line seeing COVID positive patients. So a huge shout out to all of you who were, and those of our CL service who were as well. And then I've been fortunate to be a part of an awesome CL research team to help us think through a lot of these issues. I'm happy to take questions.
Thank you so much, Scott. That was a tour de force, just how much you covered and in the depth, just looking at all aspects of acute and subacute COVID. So thank you for that. And there's a question in the chat, and then we can turn it over to kind of further questions. Any thoughts on post-COVID migraine, or how that might sort of come about?
Yeah, I have to say that's probably out of my area of expertise. I have certainly heard reports of it, but I don't have any great ideas in terms of what may be driving it. The endotheliitis angle is interesting, since we think of migraine as potentially a vascular issue. And so I would think about effects of COVID on the vasculature. But beyond that, I don't have a great sense of that.
Okay, we can open it up to questions from the audience. Please just unmute and feel free to ask.
I have a question about akinetic mutism. What are other instances in which we see that, and how do we often distinguish between that and catatonia?
Yeah, so we probably see it a lot more than we recognize it, I would say, similar to catatonia in that way. It's a phenomenon that I did not have a lot of familiarity with, something that I had heard about in fellowship and sort of read about, but hadn't seen a lot of until we started seeing some of these COVID patients. My understanding, and I think actually Davin is much more of an expert on this, but my understanding is one of the phenomena in which we do see akinetic mutism is in delayed post-hypoxic leukoencephalopathy. And that's one of the more common instances in which it occurs. And some neurologists would say that that's kind of the most common manifestation of DPHL, very much looks like an akinetic mute picture. Classically, it was described in certain structural lesions, in brain injury, sometimes in space occupying lesions. And so there was this idea that it had to have a structural underpinning. But I think now the thinking has shifted to understand that things like inflammation and other processes that affect the brain can also lead to it. Davin, anything you would add?
Not really. I mean, I agree. Having not sort of been on the CL service and seen, cases of AK related to COVID infection or COVID delirium, I would just sort of, think about, is there something about COVID that seems to preferentially target the white matter structures that may be related to the circuits that can lead to akinetic mutism, particularly if it's going in sort of, perhaps, through the nose and going to the orbital frontal cortex, that perhaps that area could be interesting to look at. There's another question in the chat. Any thoughts on using immunosuppressants like cyclophosphamide, considering positive antineuronal antibodies?
Yeah, I think it's a really interesting idea. I haven't seen it done. And I would imagine that there's some thought that it's not quite ready for prime time, but I do think in cases where we don't have a great explanation for what's going on, where it looks like a picture that might be consistent with an autoimmune encephalitis process, I think it's very much worth thinking about it. I will say I've seen some cases where COVID encephalitis was on the differential and a patient got IVIG and got better, but we were never able to say definitively that, that was the cause as compared to several other things that might have been going on.
Great. Another question. Someone read recently that 4 factors associated with long COVID prediction and occurrence have to do with viral load early in illness, presence of particular autoantibodies, possible Epstein-Barr virus reactivation, diabetes. Any thoughts or comments about this? That's actually from Dr. Delmore, sorry.
See, this is great. This is exactly what I meant by I learn more when I do these talks than I have to offer. So I haven't seen that. And to me, that's fascinating, particularly this part about reactivation of Epstein-Barr virus. I think one of the things that has come out of this whole discussion around long COVID is a renewed interest in post-viral syndromes in general. And, this old idea that Epstein-Barr caused chronic fatigue syndrome, I think was largely dismissed, and that's sort of been resurrected as a hypothesis, and maybe in some ways related to what we're seeing with long COVID. So I would say, those things make sense to me, particularly given that we saw some of the highest rates of long COVID were among healthcare responders in the first wave. So you would think about those individuals as having massive viral loads, probably early in the illness, maybe not the other 3 so much, but it's interesting. I think that's an area of future investigation over the next couple of years.
Great, thanks so much.
Any other questions? We have a few more minutes. Scott, if I may, again, I was not on the consult service or on the front lines during the initial wave, but I seem to recall that the delirium and the agitation associated with the delirium could seem to be sort of like really, really intense, really difficult to treat, often not responding to sort of the typical doses or regimens that we used. And so did you find that kind of you had to use heroic measures in certain cases? And what were some of those like cases like, if you recall?
Yeah, we did, and that was one of the things. And I should not use the we there. Or my colleagues did, who were on the front lines, and one of the things that was hard to figure out was it COVID or was it all this other stuff that was different because of COVID? And so these patients were getting bombed with sedation way more than we would typically use. They were starting to use novel agents. Suddenly ketamine was being used throughout the hospital for sedation. And so there were all these other factors that we thought might be playing into these really significant degrees of agitation. But absolutely. And we ended up, that's part of the reason, the algorithm has like 6 steps, and usually we're not getting to 6-line agents when we think about managing delirium. And that was part of the reason why we constructed an algorithm that had so many different agents, because we were finding that it was really requiring a combination of multiple classes of drugs to manage these patients in a way that we weren't used to seeing for delirious patients.
Super, thank you. We have time probably for one more question.
I guess I'm kind of curious at what point you would move down to the next line of treatment. Where do you decide that your first line regimen, melatonin in this case, is failing?
Yeah, it's a great question, and it gets so much at sort of the art of this, which is really tricky to capture in an algorithm. I would say one of the things that we really thought about was kind of the overall risk-benefit ratio and the cumulative effect of medications. So we were not hesitant, we moved pretty quickly past melatonin. Unless somebody who had a pretty simple hypoactive delirium, we kind of knew that they were going to need to at least go to the next line. So our decision points were really, when do we add an antipsychotic? And then when do we add something like Depakote or Trazodone? And I think it really depended on the degree of the agitation and oftentimes the sort of risk to the primary team. That was something that was new for us in balancing. I mean, obviously we always worry about sort of patients striking primary team, but a wandering patient with active COVID is actually a much bigger problem than a wandering patient who's delirious who doesn't have COVID. And so I think we erred often on the side of more medication than we might in garden variety delirium.
Super. Well, once again, amazing talk. Thank you so much, Scott, for agreeing to speak to our department, and really great to host you. And we are excited to kind of hear about what you guys figure out about long COVID. So maybe in a year we'll talk again.
Likewise. Thanks, everyone. It was great.
Thanks so much.
Great to be here.